mortality. That's a very, very significant, so it's a very significant cause of mortality. But as time has gone along, the percent of deaths among women of reproductive age has decreased. And if you look at the bottom part of the slide, the left side, it shows the annual rate of reduction. So from 1990 to 2015, the rate of reduction has been accelerating to the point where now every year there's about a 3 to 4% decline in maternal mortality. Let's look briefly at some of the causes of maternal mortality. It's divided into direct and indirect causes. The most common cause is hemorrhage, followed by high blood pressure, sepsis, abortion, and other direct causes, and then indirect causes. This is a very interesting study, and for the clinicians among us, I recommend taking a look at it. What this did was to examine what are the causes of maternal mortality beyond simply the slices in the pie that look generally at hemorrhage and infection. And what this study found was, again, the leading cause of maternal mortality is still hemorrhage. Infection is number 2. High blood pressure is following that, abortion and ectopic pregnancy, and other complications or diseases. I know that's tiny, I'm going to keep going. This makes it a little bit clearer. So what this bar chart shows is for each cause of mortality, for example, the darker blue part of the bars shows mortality from high blood pressure. Kind of beige, light brown color shows mortality from hemorrhage, from infection, and from other causes. The point that I want you to take home from this particular slide is that the other causes category is equal to the number of deaths or the percent of deaths from hemorrhage. So why is that? Why is that? It's because the indirect causes of maternal mortality are a wastebasket. There are a lot of different, oh, I'm sorry, is it hard to see? Okay, thank you. This includes anemia, it includes malaria and dengue, lung disease, which is probably TB, but tuberculosis, but possibly other diseases as well, heart disease, liver disease, and so on. So therefore, what we can say is that by breaking down the categories of maternal mortality into direct and indirect causes, we can begin to understand what interventions are going to be most effective in controlling maternal mortality, and equally important, when those interventions should be used. For example, in the prenatal period, prenatal care is most helpful in addressing indirect causes of maternal mortality. This is including diagnosis and management of anemia, diagnosis and management of heart and lung disease, again possibly TB, kidney and liver disease, and chronic high blood pressure. It also involves diagnosis and treatment of infectious diseases such as malaria, dengue, HIV/AIDS, kidney infection, and so on. When we move to the time, the critical time for both mothers and babies, which is the period immediately before, during, and after giving birth, what we see is that we need a different set of interventions to try to decrease maternal mortality. For example, we need skilled birth attendants, in other words, midwives or physicians who are trained to not only provide safe delivery, but to manage potential complications such as hemorrhage. We need emergency obstetrical care, including cesarean delivery. We need prevention and management of bleeding after delivery, and that involves things like labor practices, giving a woman medications to help her uterus to contract and not bleed, the availability of blood, and the availability of laboratory services. Also diagnosis and management of high blood pressure in pregnancy, and prevention and management of sepsis, which is overwhelming infection. I want to talk briefly about the special case of abortion, because you'll notice in this slide, abortion accounted for 9% of causes of maternal mortality. It's very important to understand that when we refer to abortion, clinicians use the umbrella term for abortion to refer to induced abortion and spontaneous abortion. Spontaneous abortion is what in lay terms is miscarriage. But very often when we're discussing statistics, these are lumped together and put together. This is another study from this particular survey, which was carried out by the World Health Organization. This is an excellent study. It looked at hundreds of thousands of women, and it looked at facility-based outcomes, which is why it's extremely helpful. What was very interesting about this particular study is that they could not distinguish between spontaneous and induced abortion, because the data quality did not permit them to do that. And so because they were not able to distinguish between miscarriage and induced abortion, it's not possible to determine the proportion of complications. I think it's the last paragraph there. It says, it is also not possible to determine the proportion of complications attributable to safe or unsafe abortion. This is very important because we need to understand the epidemiology around abortion, but the data, as I say in the slide, cannot distinguish between miscarriage and abortion as causes of maternal mortality and morbidity. So as a result, the data don't support that unsafe abortion is a significant cause of maternal mortality because we are not able to distinguish between induced abortion and spontaneous abortion until there are better data. Now, complications of induced or spontaneous abortion are very important causes of morbidity and mortality, especially septic abortion, which is infection, and clinicians must be able to manage these complications. However, I want to point out to you that one of the most effective interventions for reducing maternal mortality is maternal education. And I didn't put a slide in on this, but if you look at countries with high maternal mortality, you look at countries with low female literacy, you'll find an exact correspondence. So in this particular part, again, this is WHO data, this looked at education and severe maternal outcomes, such as maternal death, across a number of countries. What they found was that if a woman was not educated, she had a 5 times greater risk of dying in childbirth as compared to someone who was educated. Moreover, it didn't matter whether she was in a wealthy country, a poor country, or a middle-income country. So maternal education is one of the most powerful preventive factors against maternal mortality. And this has very significant public health implications as far as our emphasis on education of girls. I want to talk a bit about family planning. Family planning should be voluntary, not coercive. We have a long and ugly history, even in the United States, of coercive family planning programs. And these actually date from the early 1900s. There was a sense that people with desired traits should be allowed to reproduce, while those with less desired or undesired traits should have reduced rates through contraception, abortion, or sterilization. And this reached its apex in the Nazi regime. However, one common motive that we hear for family planning is to control population growth. And this is widely accepted as a present danger, but the dire predictions from the 1960s that we'd be running out of food and clean air and water have just not occurred. Why is that? Because human beings are ingenious. We find solutions to our problems, and it's human capital and human ingenuity that enable us to overcome the obstacles and problems that we find. In fact, many countries, including my own, now face the opposite danger, which is called demographic winter, where declining birth rates, which are often influenced by government efforts to control population, lead to population decline. And this is occurring especially in Japan, China, and Western Europe. I want to talk a little bit, these are slides that are borrowed from my good friend Uju Akocha, who's a Nigerian women's rights activist. And she has made the point that Africa is home to 1 billion people. It's really a wonderful statistic. And there's incredible diversity, so there's not one African culture, but there are common threads that run throughout the various African countries. However, at the same time, we do have remarks like this when countries still have 7 to 8 children per woman. About famine in Ethiopia. Is that good? Oh, okay, sorry. This is a British social scientist saying that we, humans, are a plague on the earth, that it's coming home to roost over the next 50 years or so. I think that he made this comment 2 years ago. We limit our population. We keep putting on programs about famine in Ethiopia. Too many people there, they can't support themselves. And as I showed you earlier, Ethiopia's maternal mortality rate is continuing to trend down. I want to talk a little bit about population. This is a very fascinating subject. It's definitely a complex subject. So what this particular graph is showing is United Nations forecasts of African population. Now you can say what part of Africa? Well, they're looking at it as a whole. And these are estimates. And what you can see is that in the orange lines are high estimates, and the blue lines are low estimates. You can see these are widely divergent estimates. You can also see that they're going out to 2100. Now, I don't know about you, but any estimate 80 years in the future is bound to have a relatively high margin of error. The second is that these estimates, if you look at UN estimates and forecasts of African fertility, they tend to increase. Let me explain this slide just a little bit. What it's showing with the orange line is estimates of fertility rates from 2008. What it shows in the green line is estimates from 2017, and from purple is 2010. So typically, you hear people involved in demography, which is the science of human population, saying there's this incredible population explosion going on, so on and so forth. There's evidence to state that that is not, that's a simplistic explanation for a complex phenomenon. What this is showing is that this is World Bank development indicators looking at total fertility rate. And what you can see is that since about 1980 to 1985, fertility rate for women in Africa has been steadily declining to be right now between 4 and 5 children per woman. This is a bit of a complicated graph, but I think it makes a really good point. What it's showing is that in many societies, and I saw this when I was in Niger earlier this year, and I asked a lady, you know, how many children would you like to have? And she said 6 or 7. I said, why? She said, 2 will die. We need 2 to help us stay home and help us, and I want to send 2 to school. So it's a brutal calculus. She recognized that, you know, 2 of her children are going to die. So if she wanted a couple to go to the city and get their education and move forward, and still needed 2 to stay with her, that was her way of, I mean, she had thought this out. This was what her plan was going to be. And this is a typical societal trend. Where child mortality is high, women feel the need to have more children, knowing that some proportion of them are not going to make it. And if you look at this graph, and I'm break this down just a little bit, you see at the bottom left hand of the graph, countries in green. These, or actually teal, those are European, North American, and then New Zealand and Australia. Up at the top, you see in the left side of the graph is fertility. The bottom is child mortality. So what you see is that where child mortality is high, women want to have more children. Where child mortality is low, women want to have fewer children. And so, and this is measured as deaths of children under 5 per 1,000. And so what you see is that many countries in Africa are distributed along this. This is a continuum. So this shows 2 things. Number one, it shows that you cannot view Africa as one consolidated stew of countries. There's significant diversity, statistically, ethnically, demographically, and you have to take that into account. The second thing is that fertility is not distributed along the lines of women, every woman in Africa wanting to have 7 or 8 children. There are diverse cultural reasons, there are diverse practices around fertility. And in fact, when you look at fertility as being higher or lower than expected, what you find is that most countries, or many countries, are slightly above or at a fertility rate that might be expected where child mortality is. I do want to talk a little bit more before I move on to the next subject about the African context. So across Africa, the average density of people is 36.4 per kilometer squared. For Western Europe, there are 72.9 people per kilometer squared. And if you look at the true size of Africa, and this is quite fascinating to me because when you look on maps, you really don't have a very clear idea of exactly how large Africa is. So Africa could hold the United States, Western Europe, Eastern Europe, China, India, and Japan, all in Africa. That's the sheer size of the landmass of this continent. You got your picture, sir? Okay. So the point that this is trying to make is that the idea that Africa, the continent of Africa, the countries of Africa, are overwhelmed and overrun with people is simply not true. This is another quick slide just showing the overseas development aid in the social sector to Africa since 1996. What you'll see is that population programs are better funded in education, health, water, government, and civil society, and that funding has increased steadily over the 2000s. I want to talk briefly about unmet need. We hear a lot about unmet need in terms of contraception. And the concept is based in the theory that there is vast unmet need for contraception and that we need to focus on this for women. The theory states that by increasing use of contraceptives and contraceptive prevalence, there will be a substantial reduction in abortion and maternal infant deaths. Unmet need is a statistical concept that does not link directly to health indicators, and the evidence that it has an impact on maternal mortality is inferential. It doesn't measure the desire to practice contraception or access to contraception. Not using contraception is not the same thing as wanting or needing contraception. Not all women want to use it. Finally, the concept of unmet need does not address whether women would be disappointed or seek an abortion if they became pregnant. To state that someone needs something implies that it is necessary or that they feel the lack of it in their lives. Taken literally, family planning means jointly considering and planning when a couple decides to attempt to achieve pregnancy. That is the creation of a new human life and a new family. However, we cannot decide that we want to become pregnant when we want to. And then abortion cannot be considered as a means of family planning because it destroys a new human life. The ICPD program of action, which was arrived at through an international consensus process, clearly stated that government should take the appropriate steps to help women avoid abortion, which in no case should be promoted as a method of family planning. Abortion is never safe for a developing human. And abortion is not health care. There's evidence lacking to support its inclusion in women's health care. This was clearly shown because the generation of physicians that I trained with, I won't tell you how long ago that was, but when they trained, abortion was not taught in medical school and it was not taught in residency programs. At the same time, you look at the impressive gains in reducing maternal mortality, reducing women's death from cervical cancer and other diseases. And so it was not necessary to have this in order to adequately take care of women. And I'm about to close here, but based on the dignity of the human person, abortion violates the inalienable rights described above. Family planning should protect life according to what the couple wants. The goal of family planning, including delay of sexual debut and pregnancy, is ultimately healthy timing and spacing of pregnancy. As noted above, taken literally, family planning means jointly considering and planning when a family will be started through pregnancy, the creation of a new human life. Couples should therefore choose on their own how to plan their family with the goal of achieving healthy timing and spacing of pregnancy. And also family planning should include help and support for those couples who are having difficulty conceiving as well. So I want to just end here, and this is what I mentioned earlier, gentlemen, if you can put the lights down. Can you turn the lights down for me? Okay, I have a very interesting video, and let me know if you can't see it. This is not a rendition, this is not an ultrasound, this is not virtual reality. This is an actual picture of a fetus at 4 weeks. This was captured by using a fiber optic scope. Can you see it? Okay. This is captured by using a fiber optic scope to actually visualize a living fetus in utero. You can see there's the heart. Even at 4 weeks, the hands are visible. This is the baby's face at 4 weeks. Again, you can see the heart. This is at 7 weeks. And you can see at this age, they're already moving. This is 11 weeks. You can see how well the hands are formed. That's the baby's trunk. There's the arm. That's the amniotic sac. That's the umbilical cord. And again, you can see the bones in the hand are forming. This is the umbilical cord. There's the baby's eye and face. Just zoom past this here. This is 9 weeks. That's the insertion of the umbilical cord into the baby's abdomen. And there's the hand. There's the face again. little feet. This child.
I am here to talk a little bit and share with you a little bit about the domestic or policy in the United States that we have around family planning, because specifically, some of you who were here yesterday may have heard Valerie Huber speak, and Valerie is responsible for the Department of Health and Human Services for the policies surrounding this topic globally. I'm responsible for the policies in the United States. And so we work closely together, and it is very important that our policies mirror each other and are very close together. And so what I want to share with you a little bit is the basis behind the development of the policies around family planning and promoting a plan for families. And again, I mentioned we work in a different division than USAID. However, we collaborate very closely, particularly in situations like this. And so it's a privilege for me to be able to be here with my colleagues today. When talking about what we feel like our responsibility is, Health and Human Services is a public health agency. And by public health, meaning we are concerned and we are responsible for the health of the population. And many times when you make decisions or policies about health of a population, then you have to be careful, because then again you realize you can forget about the individual people involved in that population. And so it's really important, as we're talking about policy, that we're involved and recognize, yes, there are public health messages that work for everybody, and we need to be talking about those. But many times then when it becomes an individual, you can't forget about the individual person. The Office of the Assistant Secretary for Health, the goal for them is leading America to healthier lives. My office, which is the Office of Population Affairs, is to promote health across the reproductive lifespan. That's why I'm also in charge of the Office of Adolescent Health, because starting in adolescent health throughout the reproductive lifespan, we look at all aspects of the health of the people involved in that situation. I've been in this position for about 18 months, and when I first got the job, I overheard my oldest granddaughter telling some friends, "Oh, my grandma's going to work, and she's got to control populations." I'm going, I don't really think that's exactly what's going to happen. I said, no, this is population affairs. This is not population control. But you know, it's interesting because there's a lot of misunderstanding sometimes around that situation. And don't we sometimes look at family planning as population control? I think we do, and I think we need to be honest about that in looking at that. And so part of what is important as we think through these policies is to define what is family planning. And I think sometimes we've forgotten about that. I mean, technically, to be a good English speaking person, you aren't supposed to define a phrase or word by using those words themselves, but I don't know what else to do here. Family planning is planning for a family, right? I mean, that's the best definition I can give you. And what we use for policy making in the United States right now involves the definition of family planning, that it either helps you prevent pregnancy before you are ready to have a family, or it helps you to achieve pregnancy when you have decided that you want to have a family. But all along, there's a continuum around family planning. Unfortunately, there are some that want to add terminating pregnancy as part of this, and that is not a part of family planning policy in the United States. That is something that is legal in the United States, but it doesn't fit into family planning. And in fact, our office, the Office of Population Affairs, was established in 1970, a really long time ago. And from the very beginning, the law stated that no funds that were given from Congress to our office to help to provide family planning for our population, none of those funds could be used in a program where abortion was considered a method of family planning. And so that's from 1970. That has been the law that is there. And it is important that, because that becomes part of why the definition is what it is, that these funds are used, and the policy is to help to either prevent pregnancy or to achieve pregnancy. The core family planning services that are a part of this, and I think this is important. I'm going to go over this briefly, but it's important to understand that it's a broad range of acceptable and effective methods for preventing pregnancy that include counseling about delaying the onset of sexual activity, or if already sexually active, choosing to avoid sexual activity for a period of time, if that is the choice. Instruction in fertility awareness-based methods that include staff who are specifically trained in this area, and a variety of medically approved barrier and hormonal contraceptive methods. That is considered the broad range of family planning that is offered through our office. In addition, there's pregnancy testing and maybe counseling surrounding pregnancy. But here's the part that's really important, because it also needs to include services that are centered around preconception or before you become pregnant or in between pregnancies, your health. And those things are incredibly important. And it includes basic infertility services. It involves looking at STDs, because we know a number of them will affect fertility. It involves HIV testing and screening, and also screening for substance use disorders and other things that may affect health. In helping to achieve pregnancy, and I'm going to talk about that really briefly, but the part of our office that writes policy about this is that part of understanding or helping to achieve pregnancy is that there is information that is medically accurate that is given to adolescents about puberty, about what it means about their body changing and what those things are there in a medically accurate way. Discussing the reproductive life plan. This means think about when you want to have a family, how many children you want to have, for whatever math you want to use to determine that, as Dr. Rubinus mentioned before. I think that the question that is asked is, do you want to be pregnant in the next year? And if that answer is no, then there's a conversation around, is not having sex an option for you? If that's not an option, then let's talk about ways that we can help prevent pregnancy if that's what you want. If the answer is yes, then there's a whole line of things to help people become healthy and prepare for a healthy pregnancy. But what we are recognizing is that because there are a high number of unintended pregnancies, even on contraception, and many times people might change their mind within that year of time, we need to start talking about health issues way before people want to get pregnant in the next year. And that is the new direction that our office is taking, and the new mandate that we have from my boss and then Secretary Azar to begin to focus on preconception health very early. Things like high blood pressure, getting that diagnosed early and treated. Things like diabetes and obesity, the kinds of chronic things we see, but also talking about the health issues around sexually transmitted infections and how that might affect fertility later in life. And making sure that conversation is happening when we are talking with whoever is coming into our clinics. We focus on optimal health, and I'm actually going to be talking more about that this afternoon in another presentation, but the approach to looking at a public health approach that is a primary prevention message, that we know that delaying the onset of sexual activity is the most effective way to prevent pregnancy, particularly for adolescents, but also this broad range of acceptable and effective family planning methods and services. We are required by law in our country to provide those for citizens, particularly those of low income. I would say that there is not a best contraceptive to use. And I'm going to explain that to you because as a physician, I am a pediatrician, adolescent medicine specialist. As a physician, I would have a hard time giving you a medicine that I didn't think was the best. If you have strep throat, I am not going to give you a medicine that doesn't treat strep throat. That would be very bad of me as a doctor. I want to give you the medicine that's going to work the best. The problem is when you put that with contraception, the medicine that is the most effective, or the device or situation most effective to prevent pregnancy, may not be what the person sitting across the table from you wants. And the most important contraceptive to use is the one that is going to work for the woman who is there. It is her choice. Many factors come into a choice what kind of contraception to use. And so it's very, very important to understand that contraceptive care means providing quality, patient-centered information to them in that situation. And also to ensure that they have unrestricted access to that, but it's up to them to decide. And there are many reasons. There are cultural values, there are religious values, there are country-specific values that all come into this, and it's a no judgment zone. That decision is there. We're required to provide information, and the decision and support from us needs to be whatever is chosen, whatever to be used. The patient-centered care is really defined that we're providing care that sees each person as a unique individual and emphasizes the respect and empathy to understand true what their cultural values are. To provide information, but to counsel based on their needs. And we actually have measures to look at how effectively we are achieving this goal by recording patient-recorded outcomes from how they feel like. Did you get what you wanted when you came in? Did you feel like you were respected when you talked about these issues? Were your questions answered? All of those things become a part of what we do when we are caring for clients in this situation. That's part of the policy we have for what we call our Title X clinics. We fund around 4,000 clinics across the United States, see close to 4 million clients every year as a result of this funding and the office that I'm responsible for. And so again, that becomes critically important. I do think most importantly, and I think if I had to summarize what I would say the policy is that we are really wanting to put family back into family planning and understanding that the family is that important. And this is one of the reasons. These are my 10 grandchildren. And putting the family back into family, I know I don't look old enough to have 10 grandchildren. Thank you for saying that. But again, I think that again, family, there is something that is incredibly amazing about having a family and being able to be a part of a family. But again, that's each person's personal decision. And that's what's the most important part about policy as we move forward. So we're going to transition into the next part. I'll just trade places with you if you want to do that. And Bethany is going to talk a little bit about the funding, which is, I know, probably why all of you really came, right? I'll show you as soon as it comes up. It's thinking.
Hi. All right, so our mission at USAID is, on behalf of the American people, we promote and demonstrate. Perfect. See it? All right. Our mission is, on behalf of the American people, we promote and demonstrate values, abroad, and advance a free, peaceful, and prosperous world. In support of America's foreign policy, USAID leads the U.S. government's international development and disaster assistance through partnerships and investments that save lives, reduce poverty, strengthen democratic governance, and help people emerge from humanitarian crises and progress beyond assistance. What we do. USAID extends help from the American people to the poorest and most vulnerable around the world. USAID invests in ideas that promote the lives of millions of men, women, and children by investing in agricultural productivity to countries so that they can feed their people, combating maternal and child mortality and deadly diseases like HIV, malaria, and TB, promoting life-saving assistance in the wake of a disaster, promoting democracy, human rights, and good governance around the world, and many more. Our agency works in more than 80 countries around the world with programs in more than 100, and we have a staff of more than 9,000 people working together. We partner with many different partners. USAID is passionate about tapping into the expertise, resources, and innovations of a diverse array of organizations across the private, public, and nonprofit sectors to find and implement, groundbreaking solutions to the development challenges. We partner with a variety of organizations in all shapes and sizes, and in fact, the agency has more than 4,000 different partners around the world. And if you visit usaid.gov, under how to work with the USAID section, you will find more information about USAID partners with each of these types of organizations and how we operate. If you're interested in working with USAID, it's important to understand how we work. We do not just fund projects. We're strategic in the types of activities and programs that we implement. The agency has a tool called the program cycle that looks at how we link everything we do, from policies to strategic planning, to project design, to implementation, to monitoring and evaluation, to how we incorporate lessons learned back into our policies. In addition, in Washington, we develop a series of policies, strategies, frameworks, and visions that guide how we work. For example, we have a water strategy that outlines how we will implement water programs around the world. We also have gender equality and women's empowerment policies that outline how we try to incorporate women into every program and activity we do. At each mission at USAID, we have our own country development cooperation strategy known as the CDCS. And the CDCS is important because it governs USAID's work locally in that particular country. And typically, missions have a 5-year strategy that outlines all of their goals in the different technical areas. And finally, and maybe most important, the agency's automatic directive system, or ADS, is important for you to be familiar with because the ADS is the agency's operational policies and procedures. And you need to be familiar with that because you'll need to, when responding to a certain proposal or request for application, you'll need to incorporate these documents in your approach, and your plans will help you increase the likelihood of receiving funding from the agency. So funding at USAID. So it's important to understand that the USAID's funding comes from the US taxpayers' funds, and its funding levels are set by Congress during the annual budget and appropriations process. The agency works with both Congress and the executive office to determine budget priorities for each fiscal year. And the majority of the agency's funding, more than 80% each year, goes through the acquisition and assistance process. Since the majority of funds are awarded through a competitive process, there are limited opportunities to fund unsolicited proposals that are sent to the agency. The majority of how we fund awards. The majority of USAID's awards are awarded competitively through contract grants or cooperative agreements. For acquisition, USAID utilizes contracts to purchase technical services, goods, and products from responsible parties, usually U.S. or locally based firms, to implement specific programs as directed by the agency. For assistance, USAID utilizes grants and cooperative agreements and usually partners with NGOs. For grants, USAID provides funds to a responsible grantee to implement a program with little direct involvement during the life of the program. Cooperative agreements are proposed when USAID provides funds to a partner but has more substantial involvement in contact with the partner during the project. Here are our fiscal year 2019 funding at a glance. To give you a sense of the agency's funding for programs, $17.77 billion obligated during FY19 to implement our programs. You can see a breakdown of whatever awarded. Approximately 66% of awards were made through the assistance or grants or cooperative agreements. And around 32% was made through the acquisition, so the contracts. And the small remaining percentage of funds was awarded through the interagency agreements. You can also see that in fiscal year 2019, we obligated more money from Washington than we did overseas. However, it's very important to note that most of USAID's funding decisions are made at our missions. Here's some of very important information, the registration and requirements. Before being able to bid on any U.S. government work, including here at USAID, organizations need to register in 3 places. An organization needs to obtain a Dun and Bradstreet or a DUNS DUNS number. This is a unique 9-digit identification number for each physical location of their businesses. DUNS numbers assignment is free for all businesses. Excuse me. Required to register with the federal government for contracts or grants. Next, your organization must register for a CAGE or in-CAGE codes. They are used by U.S. federal agencies to identify organizations with which they do business. Organizational based in the U.S. required a CAGE code, and organizations overseas, non-U.S., required an in-CAGE code. And finally, an organization must register in the System for Award Management, SAM, accessible at www.sam.org. And I have actually a flyer right here that's on this paper, on the table over here, that I brought many flyers, and I hope that you take them all. And it gives all the details that I'm saying right now, presenting. So for more information about the registration process, you can easily Google the DUNS and CAGE and all of them. But all of that information is in this paper. So identifying, now after you've gotten all your numbers that you need to apply, the next important is identifying funding opportunities. And there's a variety of ways to identify upcoming and current funding opportunities, and it starts with the agency's business forecast. All solicitation types are posted on USAID's quarterly business forecast. The forecast is a resource document that reflects all of USAID's upcoming business and partnership opportunities. It is updated daily on USA.gov and captured items for both Washington and the mission around the world. When USAID is ready to start soliciting proposals or application for organizations, the agency posts information at FedBizOps, also known as FBO.gov. Contracts opportunities are posted daily on FedBizOps. USAID typically uses requests for proposals known as RFPs to solicit it for grants. Grant and cooperative agreement opportunities are regularly posted on grants.gov. And additional opportunities for partnering can be found on our external site at usaid.gov/partnerships. USAID Business Forecast. This is an important resource for anyone who wants to do work with USAID. Given that the agency works in more than 80 countries, it's challenging for small or new organizations to stay on top of upcoming opportunities. However, through the business forecast, any organization can see what USAID is planning, and there is a variety of opportunities in the quarterly forecast document. We require any open competitive acquisition or assistant opportunity over $150,000 to be included in the business forecast before a solicitation is allowed to be released on FedBizOps or grants.gov. And tips for submitting a proposal or application. Once you have found an opportunity that you're interested in submitting a proposal or an application for, here are a few basic tips. First, read the entire solicitation very carefully. Within the solicitation, all instructions and requirements are found within. If you have questions, there's always an open period for you to submit questions, and I encourage, if you do have questions, to always ask them ahead of time. Before asking questions and when submitting your proposal, make sure that you follow the instructions outlined in the solicitation. The number one issue we see with new organizations is that they do not follow the instructions. It's also important that you create a very strong proposal, and this can be done in a variety of different ways. But it's extremely important to demonstrate your technical expertise. This can be done through your past performance and the personnel that you assign to work on the project or activity. And your past performance, I'm just going to stop here, does not mean that you have a history of doing work with USAID. It just means if you've been providing water or medical supplies to hospitals here in Africa, then you just would include that, and that would be your technical expertise. When evaluating proposals, USAID is looking to see which organizations will be able to successfully implement the project. And oftentimes organizations will talk in generalities in their proposals, assuming that USAID will be able to infer or make assumptions that their organization's expertise, but we are looking for very specific expertise, not generalities. And if you're new to working with USAID, consider partnering with an organization that currently works with USAID. The USAID's Office of Small and Disadvantaged Businesses Utilization offers a mentoring program to small businesses. And you can find a list of all the USAID partners on usaidspending.gov. Finally, if you do not win an award, do not be discouraged. Use it as an opportunity to learn for the next time. And you can also, which I would very strongly encourage, you can request a briefing by USAID where they will provide you with more specific details and reasons why you did not win. There's also an unsolicited proposals. We recognize that great ideas come from a variety of different places, and these ideas may not fit within our strategy of what we are doing in the country, but they are innovative and unique and have the opportunity to make a major impact. And when these are submitted to the agency, we call these unsolicited proposals. We review every proposal that comes in. However, we're very limited to funds for these types of ideas, so we ask that individuals read our guidelines for unsolicited proposals very carefully. So, to learn more, you can visit www.usa.gov for additional resources on how to work with USAID, such as online training and more. And you can join the assistance and acquisition email distribution list and follow us on Twitter at USAID BizOps. And now I'm going to turn it over to Monique to give a little bit on health, and then we're going to love to answer your questions. Thank you.
You've been very patient. I see people getting sleepy from the warmth, so just shake your hands. I just want to add just a couple of things because our portfolio is health, and so the goal of just to sort of frame the discussion, you know, Bethany has provided a lot of, I think, the key detail. And I know some of you looking at that, oh my goodness, this is just overwhelming, you know, there's just so much to it. I think the point to keep in mind is that applying for and winning grants or cooperative agreements or contracts is a process. It's a process. Most organizations that are civil society organizations that are doing work, whether it's taking care of the poor, taking care of people with TB, providing care in health clinics, are focused on the mission. And so one of the questions that your organizations really need to answer for yourselves is do you really want to pursue the funding? There's a significant burden of accounting, IT, financial management. None of that's bad, but what we find is that organizations that are very focused on their mission may say, you know what, I'm just going to continue what I'm doing. USAID is a development agency, and so even though very often civil society organizations are focused on getting their project funded, how is the particular project contributing to the development of Kenya or some other country? And this is part of what's called the journey to self-reliance, which is our administrators taking the point that the goal of foreign assistance is to end the need for its existence. What does that mean? That foreign assistance should not create dependency. It should help societies, communities, countries to stand on their own and to pursue their own development path. So that being said, some countries are further along that process than others. Because of this recognition that it's not easy for small organizations to work with USAID, there is a new funding mechanism called the New Partners Initiative. It's very easy to find on the web. And what the New Partners Initiative does is it's designed to address some of these challenges for small organizations. It is not at all restricted to faith-based organizations. Any civil society organization, any NGO can participate. But the goal is to try to increase the reach of our programs by engaging smaller partners. Why? Because when you look in India, Sub-Saharan Africa, Indonesia, you find a situation where a majority of care may be being provided by civil society. And so the goal is to support that. So I just want to encourage you because that to look at that as a potential if your organization is just getting off the ground and considering partnering with USAID. There are a variety of ways that can happen. Sometimes organizations need to be under a larger partner so that they can learn the ropes of financial management and keeping track of all of the requirements. So I do want to encourage you with that, and with that I'm going to be quiet and open up for questions.
Is there a moderator that takes this, or do we just take? Do you want?
Thank you very much for your presentation. My name is Raymond. I don't know whether you will understand this, but one of the challenges we have in a country like ours is to get the authenticity of the USA based on the government that comes in the day in the US. So looking at when it is the Republicans, we know we are in trouble. Which one is which? One of those. Yeah. So, of course, I don't know how independent USAID, I mean, you've talked about 1970, you don't promote any abortion as a method of anything, but how independent is USAID from the politics of the day? Because we may decide, okay, at the moment, USAID is friendly to our cause, our pro-family cause, but for how long? Will Trump come back? If he doesn't come back, do we go back to another fight? I don't know that you want to comment on that. Thank you.
Well,
Well, my name is Jason, and I am the chair and founder of Champions for Gender and Economic Development, CBO. And actually, the presentation has actually tackled some of my issues that are on the ground and have been brought to the platform today. Realizing all those things, whatever we're going across down there, what we go through, it's just a matter of policy issues that I'm so much convinced that this is possible. That we are very much able to tackle these problems that women and children are going down there. But we miss on one thing, our governments honoring drastic actions that can be ratified legally and are aimed at protecting the lives of women and children. My question, as a trained person on development issues, I'm actually doing my master's in St. Paul's University I'm taking MDS, Masters in Development Studies, but Peace Building and Conflict Transformation specialization. I find it quite unrealistic with the data that you've actually presented there, with the relevant research and information that how we are losing lives down there. Could be poor nutrition, especially in our area hit areas down there where women cannot get good nutrition when they are pregnant, where children cannot get good nutrition. Well, we are so worried that so much is being pumped into such programs, but we are not seeing these problems go. So what method are you coming up with or proposing to the governments of the world? What are mechanisms that you are checking? What are areas, the indicators that actually US, when you are pumping in money to such kind of problems that we are citing in this presentation, are we sure that this kind of thing, are you sure that this thing is ending or it is still escalating?
I'll answer these two questions.
I'm writing down.
Thank you for your presentation. My name is Zakwe Joyce. I'm from Uganda. I want to start by asking a question, especially within the USAID funding and your work through the CDC. From my experience back in Uganda, my question is, does the CDC component of funding promote circumcision? And if it does, on what grounds and for what purpose? And then my second area is I want to appreciate your family planning component where you said it's either to achieve pregnancy or to prevent pregnancy. And my question is, in the area of preventing pregnancy, what methods do you use? I think those are just two areas that I want to get feedback from because back in Uganda, my experience is in the area of those kind of funding, you'll find that in our health institutions, our health workers who are already trained, by the other side, they more or less like promoting their side of the story than promoting what we have. And if your organization is advancing the life and promoting and protecting life, and if you're using the natural family planning, which actually back home there doesn't have any funding, but others like contraceptive use and whatever the other side promotes, has a lot of money. And we also have funding challenges. You have seen your guidelines of your funding. And we keep asking ourselves, as faith-based organizations, where do we fit? And where is our position? How can we be helped to be pro-life? Thank you.
Hold on, I'm just writing down on this one. Okay. So the first one I have to do how will change it. Yeah, how will change it
Yeah. I think in addressing the question that you had about what can we expect with changing government, I think that's the beauty or the difficulty with democracy, right? The people get to choose who runs their country. And whoever runs the country gets to choose what priorities they have. And so, again, I can't predict to you what directions or what priorities will be for different departments based on administrations. It can be different. And as I think Bethany mentioned to you, every year, all of our agencies have to come up with budgets and with priorities. And those priorities are, as civil servants in the government, our responsibility is to accomplish the administration's priorities. I have heard and I have learned that if you want to be successful, you find out what your boss thinks is important and you get that done, right? Now, that being said, if that direction is different than what you personally can do, then your choice is to not work there anymore, right? So again, in answer to your question, I think there are differences, and we firmly believe in a country's sovereignty to decide for themselves whatever way their government is set up. That is your right as a citizen to vote, to determine who you want to lead your country and whatever way that works, and that's the same thing that happens in the United States. I do think that there has always been a priority to care for the needs of other countries based on the agency priorities that we have. That's not going to change as far as aid to countries, and there are specific priorities that I know USAID, you all can speak to that don't change back and forth. Some of that will determine, again, the way foreign aid can be used. Some of it is in law that doesn't change. Some of it is in policy that changes based on what administration is in. I know that didn't totally answer your question, maybe the way you wanted it answered, but that truly is the reality. And again, we work to provide care and to try to really listen to the countries that we work with to determine what it is that they really need, and then work on that from there.
I would say it was a very long time ago. I remember we were in someone came to speak when I was in public health school and accused the representative from USAID of being political. The fact of the matter is we are a political organization. That is the reality. And the reason that we're a political organization is because the motto of USAID is from the American people. And so inherently the goals and priorities are political, not in a bad way, but simply because we are not an organization that is not responsive to what the priorities of the American people and the administration are, if you understand what I mean. And so I think that one thing to keep in mind is the way our awards are structured are usually for a variety of different amounts of time, sometimes 5 years, sometimes 7 years, it can be extended. And so the point of the award, and I think this is sort of getting at what your question is, the point of awards and funding is to promote development. And so within the context of a specific priority that USAID has, there are awards that can help organizations to carry out those priorities, and that transcends a period of years. think the second question had to do with the policy issues and how to tackle the problems of women and children, and how do governments, I think the essence of the question is how to hold governments accountable for the needs of the population, if I'm recalling correctly. So this is a very important issue, because governments may not have the capacity in terms of governance or corruption or just where they're in settings where the government is weak, civil society is weak because they're coming out of disaster or conflict. And so this is where advocacy becomes critically important. I think the gentleman who asked the question also asked what indicators. We have a variety of indicators looking at specific outcomes in maternal and child health, in access to water and sanitation, in nutrition, in infectious diseases. And so our aid is when an organization, for example, receives aid, they have to report on those indicators. How did the work that you did using the money provided by the U.S. government help to move the needle on these particular indicators? So there are a set of indicators that measure that. In addition, there are other indicators that measure government's capacity to provide funds to help their own people and to provide funds to develop programs. And those are what are called capacity indicators and development indicators, and those are there. And I think the question that he posed, did he leave? Question? Oh, okay. Yeah, I think that the question is very relevant because at any point it is essential that we monitor our results framework. And again, this gets back to advocacy. What I think is something that I'm seeing is that communities and counties and cities are starting to advocate for their particular needs to be met. And this is a very important part of the process. Without that kind of community level advocacy, it can be difficult from Washington, D.C. to see the effectiveness. You can see effectiveness as measured on a piece of paper or with a set of indicators, but it's the people in the community who know that what you are doing is making a difference. And this is why I really encourage, I know that people in this room are very passionate about this, really encourage you to be involved with advocacy, with the Ministry of Health, and even with our USAID office here, because we genuinely do want to hear from people in the community and understand what is going on in the community. Did I answer your full question? Okay. So I think there was a question from you about circumcision. Was that the question that you had asked? Yeah. I can't speak to CDC because we're USAID, we're a different agency. So I would have to find out. I do know that under PEPFAR, the President's Emergency Plan for AIDS Relief, that there are circumcision programs that are going on. And as I understand it, the basis of that is that if men are circumcised, they're less likely to acquire and to transmit HIV. But I'm not familiar with CDC's programs. And I think the second part of your question was promotion of contraception. The contraception landscape in any country is very complicated. It's not just a question of what an aid organization like USAID or the government of Norway or the British aid organization, what they're doing. There are commercial factors as well. And the commercial pharmaceutical companies are interested in promoting their product and getting people to use their product. So there's definitely a tension in terms of what contraceptive methods are promoted in a country. There's definitely a tension, and it's a complicated situation because it doesn't just depend on what the aid agencies are doing. It depends on what the private sector is doing, what the government is doing, so on and so forth. I think that USAID has been very involved, but as Bethany said, natural family planning and fertility awareness are programs that we really support. If you're not seeing those in Uganda, that's actually information that we really need to have. And then finally, the part of your question is that you see other NGOs with lots of money, and there are funding challenges as faith-based organizations. Where do we fit? Where is our position? How can we be helped? I have to make it really clear that USAID does not favor faith-based organizations over other organizations. That being said, for many, many decades, agencies have had a faith-based opportunity office within the agencies. I think you have one in HHS, right? So Health and Human Services has one, USAID has one, there's one in the White House. And the faith-based opportunity office is an excellent liaison point because, again, that has been in our government, in our agencies for decades over multiple administrations. And it serves as a focus point for help for interacting with faith-based organizations. So we can definitely provide that information as well. But again, I just want to make it really clear, there is no favoritism for or against faith-based organizations. So.
Good morning, everyone. And thank you so much for your presentation this morning. It's been really informative and a lot to learn and appreciate, from the United States. My question will be brief. You talked about, I liked, like my colleague had said, that you don't terminate pregnancy. So that for me is really key. Thank you. But you mentioned barrier and hormonal contraceptives. And I'd like us to leave religion, culture, personal preference aside and just look at it from the medical point of view only. Do barrier and hormonal contraceptives prevent sexually transmitted diseases? And are people aware of the side effects of such?
Thanks very much for that excellent presentation. My name is Dr. Ada Buta. I'm a medical doctor. I was a surgeon, and I've actually left surgery to practice mental health because that's what I love so much. So one thing that I've been trying to sensitize people about is the Adverse Childhood Experiences Study, ACEs in the States. I meet psychiatrists, I meet psychologists, public health officials, and no one seems to understand how the adverse childhood experience, childhood trauma, affects health over a lifetime, up to reducing your lifespan by 20 years. The behavioral effects of the ACEs include depression, anxiety, suicide, early sexual debut, resulting in HIV/AIDS, pregnancy, absenteeism, drug addiction, alcoholism, truancy. So what I always try to tell people is that there's so much, the pro-life movement is actually scientifically proven that if we just focus on the family values, because for people who don't know what the ACE study is that you score childhood trauma on a score of 1 to 10. And there are 5 household dysfunctions. One of them is they include divorce and separation, addicted parent, mentally ill parent, incarcerated parent, domestic violence. The other 5 are abuse and neglect. Abuse can be sexual, it can be physical, it can be emotional. Neglect can be physical and emotional. We had a walk to talk about the mental health awareness on Awareness Day on October the 10th, and I was talking to the youth, and we were in the suicide prevention room. And when I told them about the ACEs study, and they realized that how toxic parenting was related to their suicidal ideation. And they had never heard this before, even the psychiatrists were hearing. So I think there's a very big gap. I've been trying to do all this awareness, and so I even came up with a study, using the ACEs study, how to prevent drug addiction in Kenya, alcoholism. And we even have a study it's done in Kenya, the Mathare Mental Hospital, which correlates the ACEs with the HIV, with the drug addiction, alcoholism. I think everybody will agree with me that addiction is the greatest problem in the world today, society. So, sorry, my children always tell me, "Mommy, what are you doing things with the pro-life movement and you're not getting paid anything?" But I tell them this is my purpose in life. So I have actually that proposal. But as it is now, because I've not been employed for a very long time, I've not gotten any funding. I also treat about natural family planning. I'm trained in crisis pregnancy, post-abortion healing, and I'm a recovery coach for drug addiction. But I feel that my services are not really getting out there. I've decided to retire to the village and work in my circle of influence because I don't have any funding. It's very difficult. So whatever school I go to, whatever university I can go to, I go and talk to the youth. And for me, it's enough if, like, when somebody comes and tells me, "You came and talked in my university in 2003, and I decided to abstain from sex. And I waited for the man who God had prepared for me, and I'm getting married in 2 weeks." For me, that is enough, you see. So, but I really would like to know more about how I can get the ACEs study out there, because I've refused to work with organizations that are promoting lies. I want to get the truth out there, but funding has been very difficult. Thank you very much.
Thank you so much. I'm coming from a religious perspective, but besides that, I don't know, every time somebody is holding this mic and is getting the voice not going forth. But being a preacher man, I think I need to psych myself. What I would want to contribute to us is to notice that, and I'm very thankful for what you have already contributed to us, and that is a very good scientific angle to the whole thing, or to the whole session that you are having. But I want to echo what my sister, the doctor who has just spoken ahead of me, and that we need to look at even to help governments, because within the government, even like the government of Kenya, there are people doing a lot of what we call social work, especially work with the orphan and vulnerable children. And I see, okay, I know the other side, there are some people who are advocating for prostitution, licensing prostitution, but I think there are issues of the vicious cycle of poverty affecting the people, as my brother had just spoken, and even in some areas, because sometimes people, because of maybe underfunding in the rural areas, like we had a case today in our papers of somebody who got into the gear, the wheel gears of a British Airways plane, and going, and he was a stowaway all the way to London at Heathrow Airport. But when the plane was landing, it has to release the wheels, and he has to drop about a kilometer from up, landing in a upmarket estate. It is in the papers, it can be seen. You can see that for today. But fund, besides that, there's a lot of poverty going on. Sometimes the funding should not necessarily come through the mainstream government or through the state or through the national government, as we call it here. But it is good to keep on supporting people who are pro-life, and especially through the church. I think my sister has also echoed that from Uganda. Others are calling them faith-based. And so when we light, or if you get a proposal from Africa of a person saying he's a pastor, an evangelist, a social worker, or they are church-based, or they are CBO, please consider them, because they do a lot of work where the government has left a lot of gaps. besides where maybe we use a lot of prayer to make sure, and convincing and going, spending a lot of money doing what we call campaigns or evangelistic campaigns, where we want to change people's attitude towards prostitution, dropping from school, beating their wives or battering. Use battering there. Here we sometimes we say beating. And you know, you have to educate people, as doctor has said, where you have to say that this is what is true marriage is, how to treat your partner in marriage, how to treat your children, how to do proper parenting and all that. And some of us, sometimes they are just out there, as the doctor has said, and there's no funding. And you are just doing it what they call by faith or out of pocket. And sometimes that can also affect somebody negatively, because by the end of the day, I have children, or I have a wife, or I have a family where I came from. They are saying, you are an educated guy, I'm a graduate. And then they're asking, I mean from the university, when you are educated, we expect something from you, support from the village, even right now, as my phone. And every time, support us. You don't tell them, I'm here changing people's lives, I'm here counseling children in the slums, I'm here trying to change prostitutes. They will not hear that. So funding is very key, and especially when people say they are faith-based. As you are seated right now, you are seated in a faith-based facility. The Catholic community is here. And it used to be just a bookshop down here, just a small, just a loft. What do you call those? Where you just do loafing at ground floor. But now today, it's a big facility called Cardinal Tunga, honoring a former cardinal of this country, of the Catholic Church. And so it has become a building which can become of utility. So if the government does not, if for some reasons, some issues do not allow to go to the other side. I heard somebody say the other side, anti-life. The pro-life can have facility provided by the faith-based. And for this, I say thank you to the Catholic Church. And I wonder where Kenyans are, because they should be feeling all this. All the Africans and all the states should be here, the 55 states. But my proposal is, please, when you hear faith-based, support them. Yeah, look at what Billy Graham did, what all those other guys are doing. And I believe he used to pray for all the presidents, all the successful governments. So if Billy Graham Evangelist Association is doing something, if the Samaritan Pass is doing something, and they write to you, support to them, because they help in the war in the Sudan. They shall help in the fightings, where there are overturning of governments, sometime in Africa. And so let's help the people, because we are faith-based, and we need a lot of financial support. Money doesn't know whether you are saved, or you are Christian, or you are or you are pro-life or anti-life. But pro-life need the money more than the anti-life. Thank you so much, and thank you for coming to help us. I didn't know USA works like in such an angle where they are very pro-life. Sometimes we think that much of America is anti-life. Thank you. Thank you.
Thank you very much, good people. You know, we are overrunning the next session. I think we've received very important information here. When you look at the program that you have, there is a website at the bottom there. We call it Vita et Familia. If you're here and you didn't sign up on that platform, you will miss out on information beyond ICPD25. Please get yourself registered there. We'll be sharing updates on that platform. We created this website. It is less than a month old. It is meant to pull together pro-life and pro-family groups. And we are continental in character, so that the interventions can be coordinated. We are leaving too much work unfunded with the churches and the mosques. They are hunting for money to do real programs, and they can't get this money. In this country alone, 30% of the health facilities are run by the Catholic Church. When you add the Protestants and evangelicals, we are hitting 65. So if we are not sending money to these places, where are we sending it to for purposes of answering the health question? A similar thing is happening in education. So there might be a need for the agency to reconsider its thought about the faith sector. While it is the case that there is no favoritism, whether for or against the faith-based, it might be necessary to know where to put the money that really adds value. So basically, when we help the churches to do their job, we will protect the family. The programs necessary to protect children from being aborted, the crisis pregnancy centers, Pearls and Treasures, Protecting Life Movement Trust, and all these entities, they have nowhere to get money to do the right thing and protect girls from choosing abortion. The programs necessary to grow our children into character persons don't have the money, but comprehensive sexuality education, fully funded. They are selling their programs in our radio stations, in their televisions. They can afford the slots. We can't afford these slots. And yet we are supposed to protect our children. The programs to prepare people for parenting, as she has indicated right there, the churches cannot afford the personnel to prepare people for being good married people and parenting. But these similar programs are fully funded elsewhere. So it's like we need to really consider where we are putting the money, and it's just an appeal. The structures you presented is very good. It looks a little bit red tape and technocratic for many people. But if at the policy level and at the technocratic level, the agency decides to really have a soft ear for those who are doing the real work on the ground, I think it will be really useful in transforming society. Please do.
Mark Green is the administrator of USAID, and USAID is $19.6 billion for our agency, and our focus is development. And this is what he said recently. At USAID, we see freedom of worship as an essential element in our pursuit of government that is citizen-centered and citizen-responsive. It is inseparable from freedoms of expression, assembly, association, and discrimination. Yet a third reason why is that for us as an agency to be able to accomplish our core purposes, our core mission, whether it is development or relief, we need to reach corners and communities where governments cannot go or where they have chosen not to go. We must be able to touch people who have been left behind, people who have been forgotten. In many settings, being able to partner with the community of faith, with faith-based organizations, enables us to do that. This is on the internet, okay? Faith-based partners are often uniquely trusted in those forgotten communities. They can harness networks and resources and insights that help us reach out in ways that we otherwise could not. Religious liberty matters because it enables faith-based groups to work with USAID and others without surrendering their essential faith character. So that is his position, and that's the agency position.
So thank you very much. At least there's a general change in direction. We are very thankful. Please join me in clapping for our American friends for having come to Kenya to attend ICPD25, but decided to be part of us here and share this information. We're really thankful, and we are hopeful that policy is going to change. I keep telling people the tide is changing. There's a time when we were in the minority, even number-wise we are in the minority, but it's because we don't have the money to fly in people. 5,000 fellows brought to that conference. If we had that money, we would bring them here. So we are thankful that the remnant, the minority who are here, are convinced and they're doing the work on the ground. So good people, register at that website. Let's coordinate what we are doing, anything on life and family, so that the agency, when it chooses to send $1 million in that direction, they see the impact that is going to happen. Okay. Now, I'd like to clarify, the program seems to have been jumbled up. If you don't have the program, just check it up there. At 11 o'clock, the activities listed in 9 to 10:30, starting with Raphael Gabriel downwards, those are the activities that should be happening from 11 to 12:30. Are we together? Whoever designed the program could have messed it up, but from 11 to 12:30, all those activities listed from Raphael, Gabriel, Large Hall, St. Michael, and then CPS1 should be taking place. So choose where you would like to go and attend these sessions. I'd like to make another announcement that we will have an opportunity to listen in to diplomats who have accepted to make a pro-life statement tomorrow morning. The venue will be communicated. Please register with me if you would like to attend it. It will be tomorrow morning, probably between 8 and 9. We will confirm, but please register with me your WhatsApp number so that we are able to dispatch the message to you when it is when we confirm. All right, we will have an opportunity to attend a session where a number of governments have now chosen to speak our language formally to the world. It will be in a venue that we will communicate. So you register with me after this session, and then we proceed. So in this room right now, we are in St. Michael. We are going to be having the right there. We are going to be having alternatives to the comprehensive sexuality education, human dignity curriculum by World Youth Alliance. St. Gabriel across there, we will be having parental consent in reproductive health services by the European Apostolic Leaders. And then in CPS Catholic Parochial School, room number 1, we will be having raising a Christian family. And then the large hall which is close to the Basilica, we are having a philosophical and theological question that will be handled by the Catholic doctors and the scientists who are here. The Christian doctrine of creation and the value of human life, a refutation of the false hypothesis of cosmology, geology, and biology that erode respect for human life. In simple terms, the scientist argument that we come out of evolution, not creation, is going to be challenged. Are we together? So, good people, let's scatter now so that this room can be used by the next group that is showing at the pandemic. A clap once again for our presenters. Then we start. Thank you.